Hey, well, sorry I couldn't be there with you in person. We've got some interesting annual meeting responsibilities here, so I'm glad I could join via WebEx. So this afternoon, I'm going to try to go through and explore some of the concepts of integrating care delivery and the things that you can do to think about integrating with your pharmacist in community pharmacy practice settings, and hopefully give some good examples and some resources and some ideas that will help to stimulate your thinking. So just sit back and relax and take it all in, and we'll have hopefully 10 minutes or so at the end for questions, and really looking forward to that dialogue as well. So APHA is the oldest, largest national professional society of pharmacists. We're located between 22nd and 23rd Street on Constitution Avenue in Washington, D.C., and our focus is really on improving people's health that's connected to pharmacist patient care services. This slide gives you a depiction of what we refer to as our innovation arc, and the way that we usually move along the process with good ideas. When we have one, we get a group of smart key stakeholders together, usually design a pilot, refine that model once we put it on the ground, and then go through a scaling process that has 2 or 3 cycles of CQI associated with it, hopefully getting things to a point where we can move it out to more of a national model where we can help to improve America's communities together. So I'm a big copy fan, so for me, I always try to begin with the end in mind. And where we're going is to, I hope, a better place where we have empowered patients, better collaboration, improved outcomes, and at the end of the day, a better care experience with lower total costs. In terms of the best way to get there, we really believe in putting patients first. You do the right thing for the patient, and the rest of it tends to fall into place. Doesn't mean it's going to be easy along the way, but it's usually hard for folks to take up a position against you when you've done that. Obviously, as pharmacists, we're really focused on optimizing medication use. We're keen on making sure that patients are making the best use of their medications, but we also know that we've got to have a seamless flow of information between and among all of the members of the team, and we really do believe, and our initiatives have really been all about patient-centered, team-based care. In fact, that's basically been my job for the last 22 years after I left health system practice, which is really to imagine, design, implement, evaluate, publish, and communicate about patient-centered, team-based care and the things that can happen when you get the pharmacy integrated into that team. There are a lot of forces defining pharmacy practice right now. I wanted to give you a slide with some of this information to help to kind of follow that. Obviously, we've got an aging population with the baby boomers, and we've got a lot of opportunity out there to do good. There's also a lot of new innovation in science in the space of pharmacoinformatics and pharmacogenomics and nanotechnology. So we think that in the future, the idea of actually customizing medications for each individual patient at the point of care based on their genome is not only possible, but we think it's highly likely. Let's talk a little bit about oral and systemic health and talk about some of the prevalence and consequences. I'm sure that there are a lot of you in the room who could probably be more expert on this than I as a licensed pharmacist, but we're interested in really trying to focus on where the opportunities are. So we believe that one of those places is in early childhood caries. Still the most common infectious chronic disease in our child population today in the U.S. And we think that there's an important role that could be played by community pharmacists by actually engaging with those patients. One not very well-known fact is that there are slightly over 300 million visits to the front doors of community pharmacies every 7 days in this country. It's a point of access in our healthcare delivery system that we really haven't utilized or leveraged in a productive way, and we think that engaging in this effort to actually support with both screening, identification, and referral, as well as possibly even chloride varnishes, makes a lot of sense. We have have a set of early childhood caries prevention guidelines that was approved by our organization, and it focuses on the 5 key elements of prevention, partnership, quality, documentation, and empowerment. So that's a resource that we can share if that would be helpful to any of you. When you look at this access picture for pharmacists, it's actually quite compelling. When you look at total U.S. zip codes, primary care physicians have slightly more access to the population than pharmacists, but when you get into rural zip codes, that flips. And when you get into healthcare provider shortage area zip codes, pharmacists tend to be more accessible to patients than all of the other healthcare providers combined. And so again, we aren't interested in doing this alone, but we think that as a valued member of the healthcare team, that there are some important things that we can do together. We also know that gum disease is a huge problem out there. I think these numbers are about 3 or 4 years old, so the number may be higher, but over 65 million people affected. 1 every 2 adults suffering from periodontal disease. And so there are lots of opportunities, not only in the early childhood caries space, but also in the adult population. These are some statistics related to other chronic diseases and why these comorbidities are so important, and where we think that the opportunity to collaborate among pharmacy and medicine and dentistry and nursing and other either allied healthcare professionals or even community health workers in some cases actually makes a big difference. So if you look at this problem globally, it's even more challenging than here in the United States. And I don't think that I need to go over these World Health Organization statistics again, because this audience is probably already very well studied in this area. But suffice it to say that this is still, a very important situation that we could all do better with if we figured out smarter, more effective ways to actually work together. This is the Surgeon General's framework for action in terms of really going after this issue that came out a number of years ago, and this has all been a part of our work as we've navigated with a variety of different collaborations over the years. And these are listed on the screen. We first started down this path in 2010, 2011, and have worked extensively with the Democrats Foundation, with the National Interprofessional Initiative on Oral Health, and some with U.S. NOHA, and then some very significant collaborations also with our physician assistant colleagues, where we've done some good work together. So the opportunities are out there, and there are a variety of ways that you can connect both nationally and regionally and locally to community pharmacists who would be interested in actually collaborating. So in terms of those collaborations, I want to go through and provide you with some background on some of the types of initiatives where we've seen these interprofessional processes of care, and having the pharmacists on the team to hopefully get the juices flowing for some out-of-the-box thinking about how you might actually succeed with that. This slide is a visual depiction of a variety of different initiatives that we've implemented over the last couple of decades, but suffice it to say that we've got a lot of experience in a lot of different areas and have developed process of care models for these patient-centered, team-based care approaches in all of these different areas that are checkmarked off on the slide, as well as basically analyzing them from not only a clinical perspective and looking at the traditional clinical outcomes and the quantitative data that we have associated with them, but also looking at humanistic and economic outcomes, because at the end of the day, our goal is really to make sure that we align the incentives for patients who participate in these initiatives, for healthcare providers who participate in these initiatives, and for payers who participate in these initiatives. We believe that aligning incentives to make sure that patients have reduced friction for access to their treatments, and to the ability to effectively monitor them is mission critical. We believe that each healthcare provider who participates in the process should be fairly compensated for their services. And for the payers who have the courage to change the way that care is being paid for and delivered, they too can spend less in total, as you can see from the economic savings that are depicted here on the screen. So if you look at adherence, in a typical population of patients who are on a chronic medication for a chronic silent disease, we still to this day have the challenge that's depicted here in this study from Simons et al. Back in 1996, which is to say that less than 50% of patients who are started on a medication for a chronic silent disease are taking it 12 months later. So that presents a really big challenge for us. And one of the first initiatives that we put on the ground where we armed pharmacists in community practice settings across the country with point-of-care testing technologies to actually do a full lipid profile and to get a Framingham risk assessment and to use those data in a feedback loop not only with the patient but the rest of the healthcare team. We saw some really astounding results. So instead of less than 50, actually the industry data showed that we would have had 32 to 38% of patients still taking their lipid-lowering medications at 24 months. We saw fully 93.6% who were still taking their meds at a 90.1% compliance rate, aka taking it the way that it was prescribed. And we saw over 62% of the patients actually achieving their NCEP adult treatment panel goal. So there's a lot to like about this interprofessional process of care, and this really is compelling evidence when you look at other data that's out there. So this is a comparison to the Lipid Treatment Assessment Project, which we often use as a historical norm or control because this was going on contemporaneously with our initiative. Along the lower axis, you can see that these data are broken up into risk categories, and then the percentages below them show that in the LPAT project, which just involved primary care physicians and patients, the percentages between their population and ours varied by no more than 5% in any one of these categories in both of these studies. And you can see that as the risk increases, an interesting thing happens because the goal achievement actually increases. And when you look at the existing population with coronary artery disease, in fact, you see almost a 2.5-fold increase in the achievement of the NCEP goals. So we think that this model has a lot of credence, and we think that it can help. Another area where we know that pharmacists can help based on these data is to help to be an important screening, identification, and referral source for at-risk populations. This is an example from our project in osteoporosis, where we implemented with field sonogram screening devices in the greater Richmond area and sent out advertising in print ads, radio ads, and public television ads in that community, and trying to inform patients about their potential for future fracture and who may be at risk. And fully 75% of the patients who appeared for screenings in these 11 community pharmacy practice settings were either at moderate or high risk for future fracture, which is an astounding kind of hit rate for a health screening event. And each of these patients in the moderate and high-risk categories got referred to a local physician if they didn't already have one for further diagnosis and treatment. And then those same physicians were asked to refer patients back to the community pharmacist to collaborate with them in the ongoing monitoring and management of that chronic disease. So we have evidence there. And then in the diabetes space, which I'm going to try to give you, I've got a lot of slides, but I'll do a pretty quick run through here. So this, I think, is an important comorbidity in an area where certainly, according to both the American Dental Association, who I have contacts with, as well as practicing dentists, I understand that there's quite a bit of interest in both the diabetes and the cardiovascular health space in terms of really trying to find ways to actually get good interprofessional collaboration going. We know that the toll of diabetes in the United States is, unspeakable, and we also know that when we get these interprofessional processes of care in place, the pharmacists are in a strong position to help and in a strong position to help to improve clinical, humanistic, and economic outcomes. Another area that we've done some pioneering work in is in the area of patient credentialing. So in 2003, we created the first and still the only psychometrically validated consumer credential for patient self-management in diabetes. And this consumer credential was really an attempt on our part to kind of upend the professional credentialing model. So as all of you are aware, in each of our professions, we have an approach to credentialing licensed healthcare professionals. But in this context, part of the thinking that we had is that patients are the ones who are actually in charge of managing your diabetes. Because unless you're a home healthcare provider once in a blue moon, last time I checked, as providers, we don't often get to sit at the breakfast table, lunch table, dinner table with our patients. And so our job is to actually meet them where they are and to identify opportunities for improvement in self-management that are mission critical and important to each of our patients, and to do a good job with helping them to become a more activated, more engaged, and more in control consumer when they have chronic conditions like diabetes. And so we have domains in this patient self-management credential for knowledge, skills, and performance. And in each one of these domains, patients can achieve a level of either beginner, proficient, or advanced. And the goal is that if they initially achieve only a beginner level, the pharmacist and the other members of the healthcare delivery team work with that patient to get them to at least proficient or advanced before they move on in their skills assessment processes and ultimately on to the performance assessment. If you look across the last 12 or 13 years worth of different diabetes initiatives that we've put on the ground that are depicted here on the screen, the patient self-management program, which was implemented in 5 different geographies with a variety of employers. Mohawk Industries in a little town in Georgia called Dublin, Georgia. We implemented with the Vanity Fair Corporation, corporate employees in Greensboro, North Carolina. We worked with the Ohio State University Managed Care Group in Columbus, and we worked with the Kroger Company in the Greater Ohio region, and with the Manitowoc County Healthcare Coalition up in Wisconsin. And within that initiative, we were able to replicate the year 1 results that we're seeing in Asheville from a clinical, humanistic, and economic perspective. And the patient self-management credential was one of the ways that we did that. We then moved along to the Diabetes 10 City Challenge, and in implementing that program with 34 different self-insured employers in 10 different cities across the country, we again were able to achieve clinical and economic outcomes that were very similar to those that we had seen in Asheville. Then we moved on to Project Impact Diabetes, which I'm going to give you quite a bit of background on because I think it's a cogent case study where you can understand some of the dynamics that are going on and some of the real opportunities that are present when you actually implement these patient-centered team-based care strategies. So in this initiative, our acronym IMPACT morphed and began to stand for Improving America's Communities Together. And there's a URL on the lower left-hand side of this screen, aphafafoundation.org/project-impact-diabetes. If you want to find out information about this initiative, I encourage you to go to the website. We have not only the quantitative data there in these medically underserved and disproportionately affected communities throughout the U.S., but we also have qualitative results where you can actually pick a community that you believe is like yours and actually take a virtual site visit, if you will, because we've got videos from key stakeholders in each of these communities, both as the projects were actually just about to get underway and then 12 months in. And you can get some very helpful perspectives from stakeholders in each of these communities about how they went about the business of implementing this program, what the needs of patients and providers and payers and others in their communities were, and how this initiative actually produced some really amazing results. When you think about it from a collaboration perspective, in these 25 different communities, we actually had a total of 407 different healthcare team members, and you can see the distribution here on this slide. And 14 of our 25 communities actually had certified diabetes educators on their healthcare delivery teams. And so hopefully this gives you some insight into the diversity and the type of distribution that can exist when you actually are collaborating with your community pharmacist in an initiative like this. When you look at the practice settings and the different places where care was ultimately delivered in these 25 different communities, there were 143 different locations where care was delivered from in total, and you can see the distribution here on this slide. So everything from a traditional independent community pharmacy to food pharmacy locations to pharmacists co-located in physician office practices and in either diabetes education or health centers and FQHCs, health clinics, etc. So there's a lot of opportunity out there in the marketplace for ways that you can actually plug in and different permutations of how that could be actually really productive and helpful. So from an implementation perspective, this gives you some metrics in terms of what happened. But basically, these included regular visits on average, a little over 5 visits with the pharmacist during this 1-year period of care, lasting on average about 40 minutes. And the patient self-management credential that I described earlier, this gives you kind of more of a visual of the different domains. The one thing that we know that for sure was happening in each one of these 25 communities as we implemented was that we had knowledge assessments to understand where the patient's strengths and weaknesses were as they began in this process of becoming a more effective self-manager of their chronic conditions. And again, if they scored initially as a beginner, we worked with them to actually enhance their knowledge levels to get them to a level of either proficient or advanced before they move on to their skills assessments and then things on a third verse over into the performance assessments. And one of the really interesting things that happened in the initiative, we were also able to identify that patients who had a score in their baseline knowledge assessment actually were higher in their baseline A1Cs than people who scored as proficient or advanced. So it was also a screening tool that helped us to move the agenda forward. In the initiative that you would collaborate with other health community providers on effectively, we engaged in minimum data set reporting on at least a quarterly basis that helped us to measure what was going on in these care delivery models. You can see the customization of care that occurred. And the patient demographics, we got a total of 1,836 patients who were evaluated. We have national results, again, that you can pick up on the website if you're interested, with an average baseline A1C of 9 and in a 1-year period. Even in these medically underserved and disproportionately affected communities, we got a lowering of 0.8% overall. So there's a lot to like, and here you can see the baseline knowledge for the people for a beginner level. Actually had a baseline A1C of 9.3, and the proficient folks had an 8.9, and the advanced folks had an 8.5. So if you didn't have even a shred of clinical data about the patients, you can actually understand based on the beginner level how to screen and identify and refer some of the most at-need patients in your population. We also saw great preventative care results and some changes here that were very positive. And when we surveyed people even a year on after the project had actually ended, 100 and 96% were still delivering diabetes care. So a real testimony to this initiative. And the short story is that regardless of the setting, the types of patients or the stations of life that these patients were in, we found that we were able to effectively empower people to improve their health through this patient-centered, team-based care strategy that actually included pharmacists. So this is a CDC NDEP diabetes resource that I think you all are aware of. Sometimes it's more colloquially referred to as the TPOD resources. So if you go to cdc.gov/diabetes NDEP/TPOD HCM, there's a whole set of resources that can help you with some collaboration if you're interested in doing that. And then in terms of the suggestions I wanted to try to give you to think about as you're trying to sort out how to invent a preferred future as it relates to your practice, we really see two different areas or roles that pharmacists and pharmacy practices are involved in. On the left-hand side of the screen is your classic kind of public health category, so the health promotion and disease prevention activities. And then down on the right-hand side of the screen, the classic health management or chronic disease management activities. And all of these chronic diseases these days tend to share one thing in common: medication tends to be a primary treatment modality, and so it's important as a pharmacist can be a great help as a member of the team. And all of them in common essentially, we've got a structured process that people participate in when they deliver those services. So there's a medication therapy review, either a targeted or comprehensive one that occurs. We provide people with a personal medication record and then medication-related action plans on people. But we also have some resources that were published back in 2013 in the Journal of the American Pharmacists Association. We actually convened a variety of stakeholders from all across the healthcare delivery spectrum and identified 7 key themes for successfully implementing and creating infrastructure in these collaborative practice efforts. There's compelling evidence to support all of this, and there's some references here if you're interested. But the best news is that you can go to the CDC website and search for their translational tools in the area of collaborative practice and diabetes and stroke prevention, and you'll find a whole series of different resources. In fact, one set of resources customized specifically for dentists and other healthcare providers may be the one that's actually most helpful. So that's a great tool and a great resource that the CDC has made available. We've moved it out through APHA and the National Alliance of State Pharmacy Associations and other channels, but it's readily available from the CDC. So this is my final slide before we take a few questions and try to have some good dialogue here today. These are the things that I'd like to leave you with at the end of the day. We're all in this together, and these collaborations all include some very key common goals. Number 1, we're all interested in improving care. Number 2, increasing that seamless flow of information between and among all the members of the team, patients included, is really important. And we think that increasing the availability of objective measures to demonstrate progress over time is absolutely mission critical to the cause. And at the end of the day, again, like I said earlier, for the payers who have the courage to change the way that care is being paid for and delivered, they too can spend less in total. So my short message is think about collaborating with your pharmacist to invent a preferred future, and my contact information is right there on the slide, and I'll invite commentary and questions from Troy now.
Yeah, join me in thanking Dr. Bluml. So we'll open up to questions, and then
Thank you, Ben, for this great presentation. My name is Brett Flynn, and just some comment and also a question. It's very your presentation is great. You talk about the patient self-management credentialing, which is very important because of we actually self-management or dental oral health for the patient is very important, very critical. Preserving children's behavior is very critical for preserving one's oral health. And also, there's a lot of similarity from what we are doing toward the pharmaceutical end. We are in the current trend, especially at UCSF, we like to do something called carriage management by risk assessment. And a lot of things that we do is instead of traditional surgical approach, like drill or fill, we try to use agents. And that can actually reverse the carriage process or how can I say, arrest the carriage process, such as use a chlorhexidine rinse, use a topical fry application, or Prevedent 5,000 plus, or the most recently use SDF. So there's a lot of similarity that between the way that we care for the patient between the pharmacy and also dentistry. My question is, as far as I can see the role of pharmacy to expand to, you guys do a immunization in the clinic, in the pharmacy, I saw that, in the when I go to Rite Aid, I saw that, the immunization shots is in the pharmacy station there. And I think that's something that we can also, immunization is to prevent, getting contract of the disease. And so I think there's a role that pharmacists can do also in the oral health, preventing the oral disease. In particularly, I was thinking about as the role of pharmacy can expand to do oral health assessment or screening. Because I see that you on your slide you have the pharmacy can do a foot exam and also the eye exam. Why not oral exam there? And also I can see that the pharmacy also can apply the topical fry application. You guys can do an immunization shot. Why not topical fry application? So all these things I think we can actually really expand the role of the pharmacy to explore the possibility. Because I don't know you miss you attend the session that we have earlier in this morning. We talk about how we can increase the access of care and also decrease the oral health disparity by help to collaborating with other healthcare provider in other disciplines and to work together to fight for the dental disease. So that's something that I was thinking about. That what do you think? What's your perception about possibly expanding the pharmacist's role in the oral health assessment, screening, dental caries risk assessment, as well as empower patients to on their oral health and apply topical fry application.
Yeah, I couldn't agree more. We've been an advocate for moving that direction, and we think that there are a lot of things, and there are changes in state practice acts that are putting us in a position where that can be more prevalent throughout the U.S. But each of those areas that you mentioned are in fact ripe for opportunities. I think that there are some infrastructure things that we all need to do as it relates to the team, and I think that sharing information and having a registry even that we could easily share information like we do with the immunization registries. But our vision is that perhaps a national registry would be actually more helpful and more productive in that context. But we think that certainly the services that you were suggesting fit nicely. And again, we think that the pharmacist is in a key position where we can help to refer patients to dentists who need, additional non-preventative types of services that might be available in a community pharmacy, even in the future. So we still think that there's a important key role because we have so many touches with patients, and the community pharmacy is an important point of access in the healthcare delivery system. And the healthcare delivery system, it enables that multidisciplinary.
Great. Okay, thank you. Also, one question. This is a more practical question. Basically, I know I don't know when the pharmacist start doing the immunization, shot for the patient, and how does that include? How does pharmacy association push for the board of pharmacy or whatever to expand the scope of pharmacy practice to including the immunization shot? I'm just thinking about what way that we can do to actually really include the oral health screening, oral health assessment, carriers assessment as a scope of practice for pharmacists.
Yeah, so I mentioned the guidelines that we had on that earlier slide that we had approved, and that was actually one of the first steps that we also engaged in with immunizations. And so that enabled some initial efforts that started things moving in a positive direction. And then APHA works together with the National Alliance of State Pharmacy Associations as well as the individual state organizations themselves to advocate where appropriate for expanded scope of practice. But we think that fluoride varnishes are a real kind of proverbial low-hanging fruit opportunity. The federal government has an initiative that you all are probably familiar with called Too Is Too Late, and we think that even pharmacists or certified pharmacy technicians in our community practice settings could be in a position to be supportive of really dealing, with that most prevalent infectious chronic disease in children. So that would be a great place to start. And we think that also establishing ways to share information the way that we do about immunizations in the registries, so that any healthcare provider who comes into contact with that patient would have access to knowing, when those fluoride varnishes had been, applied, and a few other basic key metrics that we might want to keep information about those patients to really enable that seamless flow of information between and among the members of the healthcare team.
Very good. Any other questions? Maybe I have one more question. I feel I'm very impressed by the pharmacist's role in the management of chronic disease and the way they empower the patient. And that's something that we definitely can learn in dentistry and how to do that. Self-management, patient credentialing, and all these things. I don't think we are doing enough in the dentistry, and so that's something that definitely we are. I really like the slide that you have over there. So I really, in the future, I really hope there's a collaboration, and also, the oral exam is going to be part of the pharmacist's role in the future, and because that's why I want to, and we will start maybe here today. And then right now we actually in our professional education, we have 3 pharmacy students enrolled in the oral health training. And we are very happy that they are in our team, and we actually learn a lot from them. On the medication that they're prescribing, and to the oral health related disease, as well as the prophylactic, usage. And it's really, really enjoyable to have. And wonderful to have the pharmacy student in our interprofessional course. Thank you.
Well, that's great. Yeah, that's great to hear. And also, interprofessional education is one of the most powerful enablers that we believe is going to really help to move this along in the marketplace now. Because here over the course of the last validation requirement that requires a demonstration of actual interprofessional education activities. And so now there's teeth in that, and we think that that's going to help to drive these things. And wouldn't it be wonderful if oral health could serve as our exemplar within that interprofessional education context, and then flow over into practices all across our great country?
Absolutely, because I think currently a lot of collaboration between pharmacy and dentistry is a lot of research aspect, developing the new drug, and also I was involved in the phase 4 FDA-approved clinical trial on the oral first, and so basically a lot of it is on the research level, but patient care level really we can actually collaborate more together. Yeah. Thank you, Ben. Yeah.
Great, thank you.
Thanks.
Can you ask one more question?
Oh, there's one more question.
Oh, sorry, Dr. Bluml, there's one more question. She's on the line right now.
Just one thing that really stuck out for me was the number of visits to the pharmacy regarding oral health issues. Can you repeat that number again? And was that nationally or locally?
You may have not heard
No,
that.
I'm sorry, I could just barely hear the question. Would you mind having somebody repeat it into the microphone?
You can one more time. Sorry, could you say the question one more time, sir?
So the question was, what was really impactful was how many number of visits to the pharmacy regarding oral health issues?
The question is about how many pharmacy visits were related to oral health issues.
Oh, okay. I'm not sure of that data because we didn't measure that. We just measured the total visits by people through the front doors of community pharmacies, not by category or any specific one category. But if you think about that number being at 301 billion every 7 days, that's almost the count of the entire population every 10 days in this country. And so it's an incredible point of access. And imagine the good that we could do if we leverage that. And like we were talking about, once we use oral health as a key example of how this interprofessional process of care could really benefit lots of our patients together.
Billion or million?
Million. Million.
Billion with the
Million.
Okay.
Yes.
Okay, any other questions?